Imagine your doctor does, everything perfectly.
Right, like textbook perfect.
Yeah. They find the exact right spot on your body, they carefully insert the needle, and before injecting the medication, they perform this mandatory safety check.
Which is standard protocol.
Exactly.
Right.
And the syringe tells them they are completely in the clear. But here's the terrifying part. The syringe is lying.
Yeah, it creates a total false negative, which that can lead directly to a medical catastrophe, and the doctor won't even know until it's too late.
Welcome to today's deep dive. We've got this fascinating stack of medical literature today, covering everything from vaccine guidelines to complex spinal case reports. And we are taking a really close look at a seemingly microscopic moment in medicine.
Right, a technique called aspiration.
Right. And for anyone who isn't familiar, this is basically just the act of pulling back on the plunger of a syringe for, about 5 seconds before actually pushing the medicine in.
It sounds so simple.
It does. But today, our mission is to explore why this tiny little movement is the center of a massive medical debate.
Yeah.
We're going to look at why it saves lives, why some medical fields are actively abandoning it, and most importantly, how the hidden plumbing of the human body can actually trick this safety mechanism.
Yeah, it really challenges this assumption we all have that getting an injection is just, a simple mechanical transaction.
Like finding a spot on a wall and putting a nail in.
Exactly. You find a spot, you push the needle in, you're done. But the reality beneath your skin is this highly pressurized, densely packed landscape of blood vessels and nerves.
So let's start with the baseline for you listening. What exactly is a doctor looking for when they pull back on that plunger?
Well, according to the World Health Organization, clinical aspiration is the application of negative pressure. So you pull back the plunger and you hold it for 5 to 10 seconds.
Okay.
And the entire goal here is to check for a flashback of blood entering the syringe hub.
Right, seeing that little flash of red.
Exactly. If you see blood, it means your needle tip has accidentally punctured a vein or an artery. That tells you to stop instantly, because if you don't, you're about to inject a medication directly into the bloodstream instead of the surrounding muscle or tissue where it's supposed to go.
But wait, why the 5 to 10 second hold, though? I mean, if I pull back on a syringe, shouldn't the blood just shoot right up immediately?
You would think so, but it comes down to fluid dynamics. Blood is viscous.
Oh, right.
It's a really thick fluid. And depending on the gauge, the thinness of the needle being used, it takes time for that negative pressure to literally drag that heavy blood up the narrow shaft so the doctor can actually see it.
So a quick tug just doesn't work.
Right. A quick tug just doesn't generate enough sustained vacuum to move a viscous fluid like that.
Okay, that makes perfect sense as a safety check. It's a built-in pause to prevent an accidental intravenous injection.
Mm-hmm.
But looking through all this medical literature today, there is this massive glaring exception that caught my eye.
The vaccines?
Yes. When it comes to mass vaccination campaigns like flu shots, childhood immunizations, the guidelines strongly, almost aggressively, tell practitioners not to aspirate.
I know, it sounds totally counterintuitive.
It really does. If it's a proven safety check, why skip it when we're injecting millions of people?
Well, the rationale for abandoning it with vaccines is heavily evidence-based. First, you have to look at the anatomy.
Okay.
The recommended injection sites for vaccines, like the center of the deltoid muscle in your arm.
Where you usually get a flu shot.
Right. They simply lack major blood vessels. The physical risk of hitting a significant artery in that specific spot is just incredibly low.
I mean, I have to push back a little on that. Even if the anatomical risk is low, why not just do it anyway? Is skipping this step just, a dangerous cost-cutting measure to speed up the line at a flu clinic?
It's a fair question, but it isn't about speed or money. It's actually about the unique risk profile of the medication itself.
What do you mean by that?
So historically, the severe catastrophic complications from accidental bloodstream injections involve medications like penicillin.
Ah, okay.
Yeah, if a thick particulate antibiotic like penicillin enters an artery, it can cause major tissue damage, blockages, and severe systemic reactions.
And vaccines aren't like that.
No, vaccines, chemically speaking, do not carry that same catastrophic risk profile if a microscopic amount accidentally enters a capillary.
Oh, interesting. So it's basically the combination of a low-risk location and a much lower-risk fluid.
Precisely. And we have to factor in the very real downsides of aspirating in this context.
Right, because there's a physical cost to it.
Exactly. Holding a needle inside a patient's muscle for an extra 5 to 10 seconds while you apply pressure to a plunger, it significantly prolongs the time that sharp metal is just sitting inside the tissue.
Which causes more trauma.
Yes, it wiggles the needle, it causes significantly more pain, which is, a major factor when you're vaccinating infants and toddlers.
Nobody wants to cause more pain to a kid. And there's a mechanical hardware issue here too, right? Because the sources mentioned that in global public health campaigns, they use something called auto-disable syringes.
Right, the AD syringes. To prevent the transmission of bloodborne diseases through reused needles, public health campaigns rely on syringes that physically lock after a single use.
They just jam up.
Yeah, the moment you push the plunger down, an internal mechanism jams it. And many of these designs make it physically impossible to pull the plunger backward in the first place.
Oh, wow. So you physically couldn't aspirate even if you wanted to.
Exactly. So for vaccines, relying on accurate anatomical landmarks completely replaces the need for that 5-second rule.
Okay, so vaccines are sort of the bumper cars of injections, low-risk fluids in safe zones where you don't really need a seatbelt. But what happens when we change the fluid to something highly dangerous and we move to a part of the body that is basically an anatomical minefield?
Well, then you are moving into aesthetic medicine, specifically dermal fillers.
Right, the cosmetic injections used in the face to add volume or smooth out wrinkles.
Yeah. And unlike the shoulder muscle, the human face is a highly vascularized area. It's just densely packed with this complex, interconnected web of arteries and veins.
And a dermal filler is not a thin liquid like a vaccine. It's a thick, heavy gel.
Which completely changes the physics of an accidental bloodstream injection. If you accidentally inject a thick dermal filler into a facial artery, that gel acts as a solid plug.
It just stops everything.
Right, it blocks the flow of blood entirely, and this leads to a condition called skin necrosis.
Which sounds awful.
It is. The tissue surrounding the injection site is suddenly starved of oxygen, and it literally dies and ulcerates.
That is horrific.
Yeah.
But it gets worse, right? Because of how the arteries in the face are wired together.
It really does, because the pressure from pushing the syringe can force that thick gel backward against the normal flow of blood.
Wait, backward?
Yeah. This backward movement can push the filler up the vascular network until it reaches the central retinal artery, which supplies blood to the eye.
Oh, no.
Yeah. If that artery gets plugged by the filler, the patient suffers instant permanent blindness.
Wow. Just from one wrong injection.
Exactly.
Yeah.
So because of this extreme risk, aesthetic protocols mandate a slow, deliberate, multi-second aspiration before injecting even a single drop.
But how long do you actually have to wait to see blood if you pull back on a thick gel, though? I mean, going back to your point earlier about fluid dynamics, pulling blood through a thick gel has to be incredibly difficult.
It is so difficult that one prominent aesthetic clinician, Dr. Tim Pierce, actually conducted a self-experiment to prove the physics of this to other doctors.
Wait, a self-experiment? How did he test that?
He hooked an IV to his own brachial vein, that's the large vein in the arm,
Okay.
and then he attached syringes filled with various dermal fillers and pulled back the plungers to apply negative pressure. He literally timed how many seconds it took for his own blood to travel through the different gels and become visible.
That is some intense dedication to science.
But the data he got was vital. He proved that if you are using a very thick filler in a thin needle, a quick 1 or 2 second aspiration is just completely useless.
Because it's too thick.
Right, you might pull back, see no blood, think you're safe, and inject. But you just didn't wait long enough for that thick gel to yield to the vacuum. The blood was on its way up, you just didn't give it the 5 to 7 seconds it needed.
So the thickness of the liquid can totally sabotage the safety check.
Yeah.
But what if the problem isn't the liquid? What if the problem is the needle itself physically drifting off course while it's deep inside the tissue?
Then we have to look at dentistry, where millimeter precision is the only thing standing between a painless procedure and agonizing nerve pain.
Right. I mean, if you've ever had major dental work, you've probably had an inferior alveolar nerve block.
Yeah.
This is where the dentist has to numb the major nerve that runs deep inside your lower jaw.
Yeah, they have to advance the needle pretty far into the dense tissue at the back of your mouth to reach it.
And this is where the physical shape of a standard medical needle causes a massive problem, according to the sources. A standard needle doesn't have a symmetrical point like a pencil. It has a single bevel.
Right, it's sliced at an angle on one side to create a sharp tip.
It's essentially a wedge. I like to visualize it like a boat rudder. If you have a boat rudder angled to one side and you push the boat straight forward through the water pressure against that angle forces the boat to drift off to the side.
That is a perfect mechanical analogy. In human tissue, this is called needle deflection.
Needle deflections.
Yeah. When a dentist pushes a monobevel needle straight into dense jaw tissue, the physical resistance against that angled tip causes the needle to veer off its straight path. It curves.
So it's actively steering itself away from where you want it to go.
Exactly. And if you're trying to hit a tiny nerve bundle deep in the jaw, even a millimeter of deflection means you miss the target entirely, and the patient feels the drill.
So how do they stop the needle from drifting like a rudder?
Modern dental techniques utilize something called bidirectional rotation. So instead of just pushing the syringe straight in, the dentist rotates the needle 180 degrees back and forth between their thumb and forefinger as they advance it. Left, right, left, right.
So they are constantly changing the direction of the rudder, which cancels out the drift and keeps the needle moving in a perfectly straight line.
Exactly. But the most fascinating physical byproduct of this rotation is what happens to the penetration force.
Oh.
If you just push a needle straight in, you're essentially plowing through tissue. It takes about 70 grams of force to push through. But when you rotate the needle back and forth, you change the mechanics from plowing to slicing. It acts almost like a micro-serrated blade. And the required force drops from 70 grams down to just 30 grams.
Wow, that is a massive drop in physical resistance.
And that drop is crucial for safety. It gives the dentist much better tactile feedback. They can actually feel the different layers of tissue as they move, which makes the mandatory aspirations they have to perform along the path much more accurate.
Speaking of mandatory aspirations, dentistry also utilizes some high-tech hardware for this, right?
Mm-hmm.
The sources highlight the single-tooth anesthesia system, or STA.
Yes.
This is a computerized delivery unit. But before the dentist even puts the needle near the patient, the machine forces them to do a 5-second aspiration check in the open air.
Right. They hold the handpiece horizontally, express a tiny drop of anesthetic out of the tip, and then the machine automatically pulls negative pressure for 5 seconds. The dentist watches to see if that drop of fluid gets sucked back into the needle.
But they aren't checking for blood here, obviously. They're checking for air leaks in the plastic tubing of the machine. Why does a tiny air leak ruin the whole procedure?
It basically comes back to the physics of a vacuum. Liquid cannot be compressed, but gas, like an air bubble, can be compressed and expanded.
Okay.
So if there is even a microscopic air leak in the handpiece, when the machine tries to pull negative pressure to check for blood deep in the patient's jaw, that vacuum energy is wasted just expanding the air bubble in the tube.
So the suction never actually reaches the tip of the needle.
Exactly. The air bubble acts like a shock absorber for the vacuum. The machine would show a negative aspiration, but it's a mechanical lie. So that open-air pretest ensures the hydraulic plumbing is completely sealed before they ever touch the patient.
Okay, so we've covered the physics of thick liquids in the face and the physics of needles drifting in the jaw. Now let's look at what happens when an injection requires extreme MacGyver-level physical safeguards, because the surrounding anatomy is genuinely terrifying.
Right. We are moving to the back of the throat, specifically treating a condition called a peritonsillar abscess.
Right. And if you've ever had a severe throat infection, you know how painful it is just to swallow. A peritonsillar abscess is a localized collection of pus that builds up in the tissue right behind your palatine tonsils.
Yeah.
To treat it, a doctor has to go in with a needle and suck out that pus to relieve the pressure.
But navigating a needle in this space is an absolute anatomical minefield. The tonsil is wrapped in a capsule, and right behind that capsule is a thin wall of muscle. But the terrifying detail is what lies immediately behind that muscle.
The internal carotid artery.
Yes, the massive artery that supplies blood directly to your brain, and it sits approximately 2.5 centimeters posterolateral to the tonsil.
2.5 centimeters. That is barely an inch. Imagine having a patient who is in excruciating pain, who probably can't open their jaw very wide, and the doctor has to navigate a sharp needle just 1 inch away from the carotid artery. How do they even maintain spatial awareness in a wet, dark, confined space like the mouth?
They have to rely on strict geometric rules and physical barriers. Because the margin for error is essentially zero, doctors will often fashion a DIY needle guard.
A DIY guard, like they make it themselves.
Yes. They take the hard plastic cap that comes over the needle, they cut exactly 1 centimeter off the bottom end, and they tape the rest of the cap back onto the syringe.
Oh, wow. So only the final 1 centimeter of the metal needle is exposed? It physically prevents them from pushing the needle deeper than 1 centimeter into the throat tissue.
It is a brilliant physical failsafe. Even if the patient flinches or moves, the needle cannot physically reach the depth of the carotid artery.
That is so smart.
But depth is only half the battle. The other half is the angle of approach.
Right, because the artery isn't directly behind the tonsil. You said it's posterolateral, meaning it's behind and slightly off to the side.
Which brings us to the golden rule of this procedure. The syringe must be advanced exclusively in the sagittal plane.
The sagittal plane, meaning straight front to back, like an arrow.
Exactly, straight anterior to posterior. There can be absolutely no lateral angulation. The doctor cannot tilt the needle toward the left or the right.
Not even a little bit.
No, because if you angle it laterally, even with that shallow depth guard, you are pointing the tip of that needle like a spear directly at the carotid wall. So the doctor moves perfectly straight back, continuously pulling negative pressure on the syringe.
And when they hit the pus.
The moment they hit the pocket of pus, it flows into the syringe and they stop. But if they drift sideways, the consequences are instantly fatal.
It really puts into perspective how much invisible, high-stakes architecture your doctor is navigating while you're just, sitting in a chair. Which brings us to the final and undoubtedly the most unsettling scenario we found in the literature. What happens when you use the depth guards, you check your angles, you hold the aspiration for 5 seconds, and the human body still tricks you.
Yeah, this brings us to the spinal epidural paradox.
Right. And this section of our sources perfectly answers a really difficult question surrounding this topic.
Yeah.
What specific pre-injection aspiration protocol, like holding for 5 seconds, is actually required when injecting near the dense anterior venous plexus in the spine?
Right. And to answer that, we first need to understand the anatomy.
Yeah, break that down for us visually. What does this dense anterior venous plexus actually look like?
So it's also known as Batson's plexus, and this is a massive, complex web of veins that runs vertically up and down the spinal canal. Picture a delicate, interconnected net of blue vessels just wrapping around the spinal structures.
Okay.
The crucial detail here is that these veins lack valves, and their walls are incredibly thin and fragile.
And doctors have to navigate near this fragile web during spinal procedures.
Frequently. Let's look at a specific case report from the sources. A 67-year-old woman was undergoing a C6-C7 interlaminar cervical epidural steroid injection.
Okay, so she has severe neck pain, and the doctor is trying to inject a thick, particulate steroid into the epidural space in her neck to bathe those inflamed nerves.
Exactly. And just like the dermal fillers, a thick particulate steroid is catastrophic if it gets into the bloodstream.
Right, it can travel to the brain and cause a stroke, or block the vessels supplying the spinal cord, which causes instant paralysis.
The stakes are just incredibly high. So what is the protocol? Well, the medical guidelines dictate that the doctor must attempt the standard aspiration. They place the needle, they pull back the plunger, and they hold it for several seconds to check for blood or cerebrospinal fluid.
The standard 5-second check.
Right. And in this specific case, the doctor did exactly that. They held the negative pressure. The syringe remained completely clear, no blood.
So according to the physical safety check, they are perfectly positioned in the empty epidural space.
Yes. But this procedure was being performed under real-time fluoroscopy, which is basically an X-ray movie.
Okay.
And before pushing the heavy steroid, the doctor injected a clear contrast dye. The exact moment the dye left the needle, the X-ray screen lit up, showing the dye instantly washing away in a linear pattern straight into the vascular system.
Oh my God. They were directly inside a blood vessel, even though the manual aspiration was completely negative. How is that even possible? Why did the safety check fail so completely?
It failed because of the unique hemodynamics of that delicate venous web we talked about. The blood pressure inside Batson's plexus is incredibly low, near zero in some cases.
I picture it like trying to suck a really thick milkshake through one of those flimsy paper straws. Like if you pull back too hard on the suction, the paper straw just flattens out completely and absolutely nothing comes up the tube.
That analogy perfectly explains the mechanism of failure here. When the doctor applies negative pressure to the syringe, that tiny bit of suction actively collapses the fragile wall of the epidural vein right against the angled opening of the needle.
Wow.
Yeah, the vein sucks flat against the metal. Because the vein is pinched shut by the vacuum, no blood can possibly enter the syringe.
So the safety check itself is what causes the false negative.
Precisely. The doctor sees a clear syringe, assumes they are safely in the epidural space, and begins to inject. And the exact moment they push the plunger down, The positive pressure inflates the vein, blows it back open, and the medication shoots directly into the bloodstream.
That is absolutely terrifying. You are required to do the protocol, but you essentially cannot trust it at all. So how on earth do doctors perform these spinal injections safely if they know the syringe is lying to them?
Because the manual tool is physically unreliable in this low-pressure environment, doctors have to completely abandon their reliance on it. They turn to advanced imaging and pharmacology.
So the fluoroscopy X-ray machine being the imaging part.
Yes. Watching how the contrast dye behaves in real time is the first safeguard. But the ultimate safeguard is the pharmacological test dose.
What does that involve?
Before they ever push the dangerous particulate steroid, they inject a tiny, harmless volume of liquid local anesthetic, and then they just wait.
They wait to see how the patient's body reacts.
Exactly. They are checking for systemic neurological signs. If that needle is secretly hidden inside a collapsed vein, the anesthetic will hit the bloodstream and travel to the brain. Within seconds, the patient will report their lips going numb, a metallic taste in their mouth, dizziness, or a sudden spike in their heart rate.
It's basically a chemical alarm system.
It is. Only after the X-ray dye pattern confirms the location and the patient shows absolutely no signs from the test dose will the doctor finally deliver the steroid.
So they still perform the manual aspiration because it is protocol, but it is deeply and fundamentally distrusted.
Right. It's just one piece of a much larger puzzle.
Man, it is wild how this one tiny action, just pulling back a piece of plastic for 5 seconds, changes so drastically depending on where you are in the human body. It isn't just a universal medical law you can apply everywhere,
Not at all.
right? Like for mass vaccines, you actively abandon it because the hardware locks and the anatomy is safe. For dermal fillers, you have to hold it slowly to let thick gels yield to the vacuum to prevent blindness. In the throat, it requires physical plastic depth guards to protect the carotid artery. And in the spine, the low-pressure mechanics of the veins mean the aspiration itself creates a dangerous illusion of safety.
Yeah, it really emphasizes that medicine requires a profound spatial understanding of the hidden anatomical landscape of every single patient. The tools only work if you understand the physics of the tissue you're standing in.
Which leaves me with a final thought for you to mull over. Given that manual aspiration is so subject to human error, fluid dynamics, and the collapsing veins of the spine, will the future of medicine eventually abandon the manual pull-and-pray syringe entirely?
It's a great question.
Right? Perhaps one day, all medical fields will rely on computerized, built-in digital pressure sensors, much like that dental STA system. Imagine a needle that physically locks and cannot inject if it digitally senses the hemodynamic pressure of a blood vessel. It would fundamentally change how we interact with the human body, replacing our manual guesswork with digital certainty. Until then, the next time you go in for a routine shot, you might just find yourself thinking a lot less about how simple it looks on the surface and a lot more about the incredible high-stakes plumbing right beneath your skin.